There's
John.
there's Abby Shaw, the one and only. How you
Hi,
doing?
John, get me on the panel.
Yeah, you're not. Let's see here. Hold on.
John.
There's Abby Shaw. Hold on. The one and only. That's a let me turn off that. Yeah, you're not. Let's see here. Hold on. Hold on.
Hi, John. I'm good.
Yeah,
Stop repeating that. Stop repeating that.
I know that's the Zoom. That's the YouTube. Yeah, it's a 20-second delay.
Yep. It's 1:30 a.m.
Oh, it's late there, huh?
Yeah. Stop repeating that.
Yeah. Well, to me, late is like 4 or 5. That's when.
Yep.
To me, that's
3 a.m.
those are hours that are vital for sleep. So you've been speaking a lot lately, Abby?
Yeah, a little bit.
Late is like 4 or 5. That's when. You know, Abby, what I like to do is to have neuroanatomy every day. No, really.
Yeah.
But no, of course, not one person, but have a network of worldwide neuroanatomists. You know what I mean? That 7 days a week we have neuroanatomy. No, really.
Yeah.
Of course, not one person. Would you be up for something like that and participating?
Yeah.
Okay, I'll let you know, because, you know, if we can get like maybe 20 neuroanatomists and a schedule and just divide it. If we spread it out amongst a lot, we'll have one every day. I think that's what the internet needs.
Okay.
And
Yeah,
that-
we can do that. We can line up few. I mean, I can name at least 7, 8 right away.
Okay.
Yeah.
Okay, what I'm gonna do is, I have the domain name, neuroanatomy.tv.
Yeah. Yeah.
Okay, so Neuroanatomy TV, what I propose to do is give a studio to each neuroanatomist.
Okay.
And they can use the studio when they televise. And
Yep.
they can go on the front page when I televise. And then, of course, we have to get the curriculum marked out every day. And then get the neurosurgeons, okay, which one of these do you want? Because I don't think we're gonna have a hard time getting neuroanatomists. And they don't have to be from one country, they can be from all over the world.
Yeah.
We'll see, we'll see.
Yeah.
Oh, there's a couple of people waiting, I'm not, oh, Abby, let me, Ahmed, is Abby going first?
Hi, John.
Hi, Amit.
Hi, dearest professor. How are you?
I'm fine. How are you?
It's a very long time no see, sir.
Yeah.
Okay, let me make you, Ahmed, I'll make you co-host. So you can admit people. And is Abby first, Ahmed?
What?
Do you want Abby to go first?
Yeah. I think so. Yeah.
Yeah, of course.
Yeah.
She gets a little ornery unless she goes first.
It's-
She,
I
she
just
gets,
told-
She gets testy.
No, I just told you it's 1:30 a.m.
Oh, that's right, yeah. Yeah,
Oh.
you don't realize that. Ahmed, it's 1:30 in India.
Oh,
Ahmed, I don't know why you have this late at night in Yemen, 11 o'clock.
you know,
Any particular reason, Ahmed, for that?
of course, now now we are in Ramadan. This month, all people just get awake for a long time at night, and you can say sleep in the early morning, much more.
Okay, okay.
So the audience, prefer this time much more.
Yeah, I like to do my meeting. If I want to reach the most possible people from Miami, I go at like 6 or 7 in the morning. And that way
Oh,
it's okay for Africa, it's okay for Europe, it's okay for India, and it's 9 o'clock in Japan. So the only area it doesn't cover is Western United States, like California and Phoenix, but you can't cover it all in one time. Yeah, the king is doing. I see him other places too. The last couple days.
Yeah, we had.
NSI, right? NSI.
Yeah, yeah, sure. Yeah, that webinar was there yesterday. It was good. Went on for 3 hours.
Yeah, we televised that. They put it
Yeah,
on. Yeah,
that's
it lasts a while, right?
yeah.
Sometimes I get lucky. Sometimes I miss them. I don't see them because they don't go big on promoting.
Yeah, they just send it to the NSI
Yeah,
group. Yeah,
and and it'll just say NSI webinar. Sometimes, like, I have to watch the beginning to get the title from someone.
actually, I
So
should have sent it to you. I organized it.
yeah, it just takes one paragraph to say, hey, we have a webcast.
Yeah,
If you could mention that to the NSI, we have a webcast. Could you televise it? Yeah, that's all I need.
I know. But I've been also traveling too much, John. It's going crazy.
Well, I mean, it covers a lot of education in India.
Mhm.
That webcast.
Yeah,
When I don't put it on, a lot of people are missing out.
yeah.
Unfortunately. Ahmed, are you ready? You want to start, Ahmed?
yes, sir. Up to you. What do you think?
Yeah, okay, let's start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from sunny Miami Beach, the home of Neurosurgical TV. We have another webcast with our Yemen friends. Yemen, Walter Dandy Grand Rounds with a couple of presentations. The first one, an old friend, Abatha Shah, and we'll let Ahmed introduce Abi. Go ahead, Ahmed.
Thank you, Jurist John. Who's Hamd Al-Ghalmi, the president of Walter Eid Surgical Club of Yemen. I'm also an executive administrator at Walter Eid Surgical Society. It's my privilege and honor to welcome you all for being with us tonight, and also to have very special guests. So first, I'm gonna introduce Professor Abitha Shah. She is associate professor in the SG, sorry, GS Medical School and Kim Hospital in the India. So, hi, dear professor.
Hi, Ahmed, and thank you for this invitation. And it's late at night here, but I will try my best to give you a good presentation. Can you see my screen?
Yes,
Right.
perfect.
Okay. So before you go on to the surgery of the pituitary gland, it is very important to understand the anatomy of this master gland, because the anatomy makes the surgery very, very straightforward. So this is our paper that we had published on the anatomical correlates and subtleties of surgery for pituitary tumors few years back. And I will show you this anatomy in two ways, from the transsphenoidal route or the transnasal route and from the transcranial route. So you have an overview of the pituitary gland. So if you look at this pituitary gland, it is quite an amazing structure. It is neither intracranial nor is it extracranial. It actually lies between the two layers of the dura, and you may say that it is interdural. It lies in the sella turcica, as you can see in this image, and I will show you the relations of the pituitary gland as we go ahead. It is closely related to the sphenoid sinus and the cavernous sinus, as you see in this image. And this relation is very important for the pituitary gland to maintain homeostasis of the body. As you know, pituitary gland secretes various hormones, and by being close to this paranasal sinus, that is the sphenoid sinus, it gets an idea about the external milieu, from the nasal air that comes through the paranasal passages, and from the cavernous sinus, the blood in the cavernous sinus gives an idea to the pituitary gland about the internal milieu of the body. So the master gland secretes hormones in accordance with this information that it gets, and it maintains homeostasis of the human body. So look at this image. Here you see the pituitary gland, and its various relations are the optic nerves superiorly, the hypothalamus superiorly, the internal carotid laterally in the cavernous sinus. Beneath there is the clivus, as you can see here. Laterally, you have the lateral wall of the cavernous sinus, and more laterally, you have the temporal lobe. Superiorly to the lamina terminalis, you will have the anterior cerebral artery complex. So you look at this image again, you see that superior it is related to the optic chiasm and the optic nerves. This is the infundibulum of the pituitary stalk, and it goes up right up to the hypothalamus. Inferiorly, it is, see, this is the sphenoid sinus, and you see how there's just a thin bone here that separates this pituitary from the sphenoid sinus. So, it gets a good idea straight from the outside environment of the nasal air that passes through these passages. So it can regulate the body temperature. Now, where does this pituitary gland sit? It sits in the sella turcica. So as you know, the sella turcica is a name for the horse saddle, and it is shaped like that. And this is where the pituitary gland rests. Various relations are, this is the tuberculum sellae, this is the planum sphenoidale, this is the chiasmatic sulcus, this is the optic canals, this is the anterior clinoid process. Posteriorly, it is related to the dorsum sellae, the posterior clinoid process, and the clival region. More laterally, it is related to the cavernous sinus here. This bone that you see here is the optic strut, which is the lower part of the floor of the optic canal. So the anterior clinoid process and the optic strut. And here, laterally, this blue structure that you see is the cavernous sinus. Now, looking at the anatomy from superiorly, this pituitary gland is covered by layers of dura. So as you know, I said it is interdural. So the dural cover of the pituitary gland is the diaphragma sellae. And this diaphragma sellae holds the whole key for pituitary gland surgery, which I will show you later. So this diaphragma sellae has an aperture in its structure that allows for the passage of the pituitary stalk. The term diaphragm, it comes from a camera shutter. So, the camera shutter adjusts the aperture so that you can, regulate the entry and exit of light while taking images. So this is the word diaphragm comes from that. Now, how does this diaphragm go? So diaphragm is a two-layered structure, and it traverses from here laterally, goes into the roof of the cavernous sinus, and then turns downwards to form the lateral wall of the cavernous sinus. So I will show you again in later images. So you see, this is the dura cut here. This is the basilar venous plexus, and this is one layer of the diaphragma sellae. As it is going posteriorly to merge with the dorsum sellae, anteriorly it merges with the tuberculum sellae. So laterally, the pituitary is related to the internal carotid artery. This is the optic nerve. The optic nerve has been lifted up here, and you see the ophthalmic artery. So now you can imagine once the pituitary tumor grows, how it elevates the optic nerve and causes field defects. So this is when the diaphragma sellae has been opened, and you can see the pituitary gland. So the anterior lobe of the pituitary gland is much larger and much darker. So this is the anterior lobe, and this is the posterior lobe. This is the pituitary stalk that has been cut. Here you can see the internal carotid artery with its branches from the cavernous part of the internal carotid artery. Here again, you see the diaphragma sellae has been cut here, half the place. So this is the tuberculum sellae. This is the region of the chiasmatic sulcus, and more anteriorly, you will have the plenum sphenoidale. Now, this is an image from superiorly, again showing the various relations of the pituitary gland. So again, this is the pituitary, this is the diaphragma sellae cut, this is the internal carotid artery, and you see its C-shaped configuration here. These are the various nerves. This is an important nerve to remember in relation to pituitary tumors. So this is the third nerve. The third nerve lies in the oculomotor cave. Here it is formed, this oculomotor cave is formed by the clinoidal ligaments, and it forms a kind of a cavern, oculomotor cavern with a CSF space through which the oculomotor nerve travels. So sometimes pituitary tumors go into the roof of the cavernous sinus and can cause an third nerve palsy, especially in patients with pituitary apoplexy, which can cause a third nerve palsy, as you might have seen in clinical cases. So this is the meningohypophyseal branch of the cavernous ICA. This is the dorsal clival artery as it is going down to supply. This is the inferior hypophyseal artery as it is going to supply the posterior part of the pituitary. This is the sixth cranial nerve, and more laterally here you see the trigeminal nerve with its branches. So coming back to the anterior view, we saw the anterior and posterior pituitary from the superior surface. Now this is the anterior pituitary gland from an anterior surface. This is the posterior pituitary gland from the posterior surface. This is the McConnell's capsular artery as it supplies the pituitary. This is the superior hypophyseal artery as it is coming to supply the anterior pituitary gland. This is how it is related to the carotid artery. It is mainly related to the C3 and C4 segments of the carotid artery. More superiorly with the optic nerve, with the ophthalmic artery. Now, when you look at it from an endonasal perspective, so this is the paranasal sinus. This is the middle turbinate. This is the bone, vomer bone, just in front of the sphenoid sinus. And here you see this is the sphenoid ostium. So here you can see the relation of the sphenoid ostium in relation to the middle turbinate. So just at the posterior part is the sphenoid ostium. Then when you go further and you remove the vomer bone, you will enter into the sphenoid sinus and you will see the sellar floor. This is the region of the clivus. This is the carotid protuberance. This is the optic protuberance. In this region, you will have the lateral optico-carotid recess. Here you have the lateral part of the cavernous sinus. Here you can see the V2 nerve in the lateral wall of the cavernous sinus. So once you open the bone and remove a part of the dura, there are many venous plexuses around the pituitary gland. So you see the anterior intercavernous sinus, posterior intercavernous sinus, the cavernous sinus itself, and the basilar plexus. Sometimes all these things are connected. The anterior and posterior intercavernous sinus are connected to each other and they form the circular sinus. So just like you have a circle of Willis, here this circle that is connecting between the anterior and posterior intercavernous sinus is known as the circular sinus. And long back, Professor Goel had written a paper and called this circle as the venous circle of relief. Why? Because by communication, it dissipates the pressure in the gland, in the eye orbit. And, it can, especially in caroticocavernous fistulas and traumatic cases like that. So it is called as the venous circle of relief. Here you see some medial attachments of the pituitary ligaments to the medial part of the internal carotid artery. More superiorly here is the optic nerve. This is the region of the tuberculum sellae. So again, this is just a bony view without the dura being removed, just the bony part which we've already seen. This is the sellar floor. This is the clival recess. This is the OCR. This is the optic canal, optic nerve impression. This is the carotid artery impression. This is the impression of the chiasmatic sulcus and tuberculum sellae. So why is this relation important? Sometimes what happens when you're coming from the nose, it is always important to see the coronal section, because sometimes these carotid arteries on both sides come very close to each other. And this happens especially in acromegalics, where the vessels are enlarged and ectatic. So when you're approaching the tumor, you might cause an inadvertent carotid injury. So if you see this image, you see this is the pituitary stalk, this is the posterior pituitary, this is the pituitary tumor in a patient with acromegaly. You see the relation of the carotid arteries and how close they are to each other. They're called as kissing carotids. So sometimes when you're coming in the transsphenoidal route and when you're going into the sella and operating and removing the tumor, you have to understand this relation. Otherwise, you will end up damaging the carotid artery. Now coming further, the dura of part of the pituitary gland has been removed. And you see this vessel that is coming from down as a direct branch of the carotid artery. And this is the inferior hypophyseal artery. Here you see the carotid artery when you look at it from an endoscopic perspective, it has a varied C-shaped configuration, as you can see in this image. Now you see this vessel that is coming directly from the carotid artery and supplying the capsule of the pituitary gland. It runs on the anterior face of the pituitary gland, and these are McConnell's capsular arteries. So in this image, you see McConnell's capsular arteries, and you also see the inferior hypophyseal artery. Here you see the cavernous sinus, the carotid artery, the optic nerves, and the region of the tuberculum sellae. Now coming to the superior aspect of the pituitary gland. So this is the pituitary gland itself. This is the pituitary stalk. Here you see this artery that is coming from here. That is the superior hypophyseal artery, and it supplies both the anterior lobe of the pituitary and the pituitary stalk. Here you can see is the optic nerves and the optic chiasm, and on top is the frontal lobe. Again, a more clearer view, you can see the superior hypophyseal artery that is coming and supplying the pituitary stalk and the anterior lobe of the pituitary. Here you see the optic nerves and optic chiasm. Here, when you open this region, you will see the anterior communicating artery and the ACA complex, and going up into forming the A2s. Here more laterally, here you can see the HCAs coming. More laterally, you can see the various nerves that are entering into the cavernous sinus, as we will see them in later images. Now, this is the whole panoramic view where the whole entire skull base has been removed to see the various structures that come from the anterior cranial fossa right up to the posterior cranial fossa. So these are the structures. So right in the middle, you have the pituitary gland, which is hanging like this. Then the pituitary stalk, the optic nerves, chiasm, the optic tract, the anterior communicating artery complex, the frontal lobe. Then laterally, you have the carotid artery. This is the ophthalmic artery as it is originating from the carotid artery. Then going down, here you see the inferior hypophyseal artery as it is supplying the pituitary. Then here you see this structure. This is the basilar artery bifurcating into the posterior cerebral arteries, giving branches of the superior cerebral arteries. You see this nerve. This is the sixth cranial nerve. See how oblique its course is. It is arising here from the pontomedullary junction and going all the way up here in an oblique direction, going lateral to the carotid artery in the cavernous sinus. So this is the relation of the sixth cranial nerve to the carotid artery. So now I have shown you the basic anatomy of the pituitary gland. Now I will show you the anatomy of this important structure, that is the diaphragma sellae. Understanding the anatomy of this structure forms the basis of approaching pituitary tumors from a transnasal perspective, transsphenoidal perspective, or an endonasal perspective. If it was not for this diaphragma sellae protecting the superior part of the pituitary gland, this transnasal route would have been difficult. So as I told you earlier, the diaphragma sellae is made up of two layers of dura. So the first layer, both the layers merge anteriorly with the tuberculum sellae and posteriorly with the dorsum sellae. Then one layer of the diaphragma sellae goes all the way. Both the layers turn laterally over the roof of the cavernous sinus, and the outer layer merges with the lateral wall of the cavernous sinus, and the inner layer forms the inner boundary of the lateral wall of the cavernous sinus. So here you can see this is a cut section. This is the tuberculum sellae where the diaphragma sellae has merged. This is the dorsum sellae. This is the aperture in the diaphragma where the pituitary stalk comes out. And then you see how this layer is going laterally and forming the lateral wall of the cavernous sinus and then merging with the dura of the middle cranial fossa. So here you can again see this beautiful diaphragma sellae as it is forming its various layers around the pituitary gland. So here you see this part of the diaphragm ocelli. So as I told you, one part of the diaphragm ocelli goes and forms this lateral wall of the cavernous spinous, and this other one also goes laterally and forms the inner wall of the lateral wall of the cavernous sinus. So this is a very important relation to remember. Part of it also covers the oculomotor nerve and forms the roof of the cavernous sinus. So this is just a diagrammatic representation showing the diaphragm ocelli. So these are the two layers of the diaphragm. This is the aperture in the diaphragm ocelli. And you see this upper layer going all the way on the roof and coming down laterally on the lateral wall of the cavernous sinus. And this inner layer of the dura coming here and forming the medial wall of the lateral wall of the cavernous sinus. And this is the lateral wall of the cavernous sinus. You can see the V1 and part of the V2 as it traverses through the cavernous sinus. So why is this anatomy important? So earlier it was thought that this diaphragm ocelli is Roton described that the diaphragm ocelli has various varied openings, and that allows for the pituitary tumor to enter and become intracranial. But that is not the case, and this has been reviewed and published by Professor Goel, who first described that the diaphragm ocelli actually is an intact layer on top of the pituitary gland, and because of this intact layer, we are able to approach the pituitary tumor through a transnasal perspective safely without entering into the intracranial region. And it forms a protective barrier on top of the gland and separates the extracranial and the intracranial compartments. So based on this understanding, we classified giant pituitary tumors into 4 types, into 4 grades. So this is the grade 1 tumor. Here you see that the pituitary tumor has gone all the way up. Here you see the diaphragm ocelli. It is elevated the roof. It has elevated the diaphragm ocelli all the way above. And even when you go in a transsphenoidal perspective, you can actually go and remove this tumor without entering into the intracranial compartment if you preserve this layer of the diaphragm ocelli. So this one, where it straight enters and grows superiorly, is the grade 1 pituitary tumor. This is another example where you see the diaphragm ocelli is got various lobulations based on the shape of the gland. But there is an intact diaphragm ocelli all the way around the tumor, and you can see that this tumor has been operated by a transsphenoidal route, and you can see the excision of the tumor. Now, what is grade 2? When the tumor enters into the confines of the cavernous sinus, when it goes lateral to the carotid artery, along with an elevation of the diaphragm ocelli or without an elevation of the diaphragm ocelli, when it enters into the cavernous sinus, it is called as a grade 2 pituitary tumor. So that means it is becoming more aggressive now. It is violating the medial wall of the cavernous sinus and going into the cavernous sinus. When is grade 3? Grade 3 is, as I told you, remember the roof of the cavernous sinus where the oculomotor nerve enters. So when that pituitary tumors grows and elevates the roof of the cavernous sinus, that is grade 3. So here you can see that the roof of the cavernous sinus has been elevated. Here again, the roof of the cavernous sinus has been elevated. And this is known as a grade 3 pituitary tumor. And when do you call it grade 4? When the pituitary tumor does not respect the boundaries of the diaphragm ocelli, when it violates the diaphragm ocelli, and you can see it has encased the anterior cerebral arteries, and this is when you will call it a grade 4 pituitary tumor. So these grade 4 pituitary tumors are actually quite dangerous to operate because of the risk of intravascular injury and also because of the nature of the tumor. So, the management of these grade 4 tumors is quite complicated. Sometimes when you try to do a radical resection, you will have bleeding after the surgery, which has been termed as fatal postoperative apoplexy. So these are tricky tumors and it is a little difficult to operate on them. Now let's look at the surgical approach for these tumors. So now first we will come from the nose. So the nasal approaches can be either endoscopic or like a sublabial transsphenoidal approach. So that is the microscopic sublabial transsphenoidal approach. So that is the approach we generally prefer to use. And here you see that this is the bony anatomy. This is the paranasal sinus, the nasal cavity and the paranasal sinuses. Here you see the sphenoid sinus. There is a bony structure here that identifies in the midline and leads you to the sphenoid sinus, and this is the vomer. It is known, when you look at it from an endonasal or a transsphenoidal perspective, it looks like the keel of a boat, and that is what it is known as the keel of the vomer. So this is the sphenoid sinus and going into the sellar floor. Now the sphenoid sinus has variations, and depending on these variations, it has been classified into three major types. Basically, depending on the pneumatization of the sphenoid sinus, there are three types of sphenoid sinus. So this one is a pre-cellar type. When this pneumatization just reaches the anterior wall of the cellar. So this is the cellar, this is the anterior wall of the cellar. When the pneumatization reaches that, it is known as a pre-cellar type of sphenoid sinus. When the pneumatization goes all the way back to the posterior wall of the cellar, as you can see in this image, then it is known as the cellar type of the sphenoid sinus, and this is the most nicest sphenoid sinus you can get to reach into the pituitary, into the cellar floor. And when you have a thick bone in front of the cellar floor and a very minimal pneumatization, this is the conchal type of conchal type of sphenoid sinus, and this is a little difficult while you are operating on pituitary tumors. So coming back to the paranasal approaches, here you see the superior, middle, and inferior turbinates. Here you see the cellar floor. Here the vomer has been removed, and you can see laterally into the paracavernous structures. So this is the clivus, this is the cellar floor. Again, see the relations of the optic nerve and the infundibulum going up. So now when you reach the vomer, the next thing you have to do is identify the sphenoid sinus. So sometimes the sphenoid sinus has many septations, and you have to break through the septation to reach the cellar floor. So here you can see in this image, this is the paranasal sinuses, the nasal cavity. The vomer has been cut here, and now we are in the sphenoid sinus going towards the cellar. Now, when you look at it, as I told you, when you look at it from an anterior perspective, this is how it looks like. So imagine that this is a boat, and this is the anterior aspect of the boat. This is the keel of the vomer. And this is the most prominent structure that you will identify when you're going sublabially. You take a sublabial incision, you remove the nasal spine, you separate the septum, and when you dissection, this is the first structure that you will identify, and this is the keel of the vomer. Just behind the keel of the vomer is the sphenoid sinus, and just beyond that is the cellar floor. So looking at the nasal anatomy, so this is the superior, middle, inferior turbinate. These are the maxillary sinuses. This is the nasal septum. So when you make a sublabial incision, this is the nasal spine that you will see. You cut the nasal spine, then you make a plane between the mucosa here and the septum, and then you can insert your speculum in this region. And once you expand the speculum, you will reach this region, that is the vomer. As you can see here, this is the vomer bone. Then posteriorly, you can see here the ostia, which I showed you that how they are related to the middle turbinate. More superiorly of the posterior ethmoid air cells. So once you open the vomer bone, you will reach into the sphenoid sinus, and beyond that into the cellar floor. So you have to look superiorly to get the cellar floor, and identifying the vomer keeps you in the midline and helps you identify the cellar easily. And once you open the cellar floor, you chisel out the anterior wall of the cellar, you will see the dura of the pituitary gland, and then you make a cruciate incision and enter into the tumor. So this is the approach that we typically use. Here you can see that this is the sublabial incision. Here you can see the nasal spine has been cut. Then you see in the midline how the keel of the vomer is identified. Here you can see in an intraoperative image, this is the keel of the vomer. Then once you open this vomer bone, as you can see in this anatomical image, you will reach into the sphenoid sinus. So here you can see that now the vomer has been opened, and this is the wall of the sphenoid sinus. Once the sphenoid sinus has been breached, you will reach the cellar floor. And once you see the cellar floor, you will see the dura of the pituitary gland, which is then opened in a cruciate manner, and the tumor is removed. So this is from the endonasal, from the nasal perspective. Now coming from the intracranial perspective, how does a pituitary tumor look when you come from it intracranially, or what are the relations of the pituitary gland with the intracranial structures? So normally, if we do, the indications for a transcranial approach for a pituitary are very few, but if we do approach a pituitary tumor through a transcranial approach, we use a subfrontal approach, and this is the anatomy that you will see. Once you open the Sylvian cistern, relax the brain, and retract the frontal lobe, this is the anatomy that you will see. This is the optic nerves on either side, the optic chiasm, the lamina terminalis, the IC on both the sides, the A1 on both the sides, the ACOM, more laterally the MCA. Here you will see that there is a ligament, a thickening here, that is the falciform ligament. This is the region of the liquid membrane. Here there will be a arachnoid when you enter into this chiasmatic cistern. And this structure that you see here is the pituitary stalk. So the pituitary tumor is coming from down below and elevating the optic chiasm. So this is the approach that we use. I don't have time to show the video. And here you see the intraoperative image. This is the optic nerve, and this reddish pinkish structure that you see coming up from the from the diaphragm ocelli is the infundibulum or the pituitary stalk. So again, this is how it is supplied by the superior hypophyseal artery, and it lies just beneath the optic chiasm. So that is the reason when these tumors grow, they will elevate the optic chiasm and cause field effects. So basically, this is the anatomy of the pituitary gland, and this anatomy actually gives you a view that you can approach this tumor using a transsphenoidal perspective. So this was a patient that we've operated using a transsphenoidal route. Some part of the tumor was remaining. It fell down after some time, and then we could come back and operate. Generally, we don't need to do that. That is an odd case. This again, another huge giant pituitary tumor, grade 1 pituitary tumor that we've operated using a transsphenoidal route. And you can see that the tumor has been excised. This is again a grade 1 pituitary tumor, which has been operated again by a transsphenoidal route. So the important concept here is that there is a layer of dura, layer of diaphragma that is actually protecting you from, entering into the subarachnoid space and causing any injury. And that's why you can go on transsphenoidal and remove this tumor. So you remove the lower portion of the tumor, and then the tumor starts falling down, and then you can, catch up on the diaphragm and actually peel off the whole tumor from the diaphragm ocelli so that it comes out. This is again another huge pituitary tumor with multiple fluid levels, as you can see here. And there are some areas of hemorrhage, and we have operated by a transsphenoidal route, and you can see the post-operative image. So I hope you have enjoyed this anatomy of the pituitary gland. Thank you very much.
Very good, Ami. Very good. Thank you, Abi. Go ahead, Ahmed.
Thank you, Professor, for the most fascinating lecture. There is a question for you. He asked that sphenoid sinus is directly posterior to vomer bone. This is a question from Ali Mukshar.
Yes, it is directly posterior. So once you identify the keel of the vomer and you break it, you will straight enter into the sphenoid sinus. So the important thing is to remain in the midline and identify the vomer. It is very easy to chisel and break the vomer, and you will straight enter the sphenoid sinus. And on the upper part of the sphenoid sinus will be the sellar floor.
So could I ask a question, bro?
Yes.
What are the contraindications for transsphenoidal resection?
So contraindications, sometimes, there are functioning tumors that go into the lateral part of the cavernous sinus, or sometimes there is a huge extension of the tumor. In a giant pituitary tumor, sometimes we go transsphenoid. But even if it is a giant tumor, the first attempt will be a transsphenoidal. If you have not been able to remove adequate amount of tumor, then we go in transcranially on the evening or maybe in a couple of days, and then go in and remove the remaining part of the tumor.
Okay, thank you. There is also someone asked that, do I have to widen the sphenoid ostia in the sublabile approach?
No, in the sublabial approach, you don't need to see. You just enter into the sphenoid sinus. Superiorly, you identify the sellar floor, and you straight chisel that area. It's a very thin bone. So within 1-2 hits, the bone will break. Then you use a upbite or something and remove that bone, and you will straight be into the. See, the sellar floor has been enlarged by the pituitary tumor. So there is a very good area that you can see there and enter into the sellar floor.
Okay, thank you. Is there any question else?
Oh, no, okay. There's Dr. Almeida.
Yeah.
Hello, everybody. Hi, John. Good to see you.
Welcome.
Thank you. Dr. Shah, beautiful presentation. Excellent. Congratulations.
Thank you, Dr. Almeida. Nice to see you. How are you
Nice
doing?
to see you as well.
Yeah.
Finally get a chance to be with you in the same session. So it's a pleasure for me.
Yeah.
And I'd like to thank you everybody for the invitation as well. I wonder, should I go ahead and start or
Sure.
okay, so excellent. So let me get here my slides. And let me know if you can see them well.
Yes. you can see
Okay,
them.
excellent.
Perfect.
So everyone, first of all, I'd like to thank you all for this invitation. I'd like to thank Ahmed Al Ghanemi that contacted me for this invitation today. And Ahmed, appreciate you inviting me. I'm João Paulo Almeida. I'm one of the neurosurgeons here at the Mayo Clinic in Florida. And I focus my practice on skull-based surgery, and I'm especially passionate about endoscopic skull-based surgery. And today we're going to be talking a little bit about surgery for pituitary tumors, and we're going to try to apply the anatomy that Dr. Shah presented it so well and use some cases as example. Before I start, I think there is somebody that is not muted. I can see some background noise on my end. So if you know, if everybody can be on mute, I'd appreciate that. Okay,
Yeah, I got it.
thank
I
you.
got it. I got it.
Excellent, thank you. Okay, so uh, without further delay, let's go ahead. I have no financial conflict of interest, but I like to share, especially with a new group. I'm original from Brazil, and I'm very proud to be Brazilian. I'm very thankful for all of those guys, and special to this gentleman right here. This is Dr. Evandro de Oliveira, a giant in neurosurgery that inspired me in microneurosurgical anatomy and share his philosophy with me and many others. And I'm proud to say that that's the school, the philosophical school that I follow in surgery and in life. I after that went to Toronto to be trained by Dr. Fred Gentili and his team at the University of Toronto. And Dr. Gentili is also, as Dr. Evandro, my mentor and my source of inspiration. I had a chance to train with Dr. Ted Schwartz, fantastic surgeon at Cornell, and to do a clinical fellowship at Cleveland Clinic in Ohio with Pablo Recinos and Veronica Chetri. And since November 21, I'm here at the Mayo Clinic, group led by Alfredo Quinones Hinojosa, and my colleague in skull base is Dr. Kai Chaichana, Nomo Lomo, and Angela Donaldson. We work together to take care of those patients. So pituitary tumors, we're going to talk a little bit about epidemiology and classification, diagnosis, treatment options, and surgery, and how we see surgery as a main treatment for those. So why is it important? Well, very simple. Pituitary tumors represent the third most common intracranial tumor, second only to meningiomas and gliomas, and you can see that in the graphs demonstrated here. This is from the United States brain tumors database, and you can see that either pituitary adenomas or tumors originating from the cell and supracellular region, they're extremely common and they occupy overall the third position in terms of intracranial tumors. When we look at the WHO classification, how we name and how we divide those tumors, there's been a lot of growth and differences over the years. In the last 15 years, immunohistochemistry has really been key. So we moved away from the classic chromophobe or eosinophilic and so on and so forth classification to immunohistochemistry classification based on the line of secretion. So we call, usually prolactinomas are caused by lactotroph adenomas, as acromegaly by somatotroph adenomas, and so on and so forth. But additional to that, now we have the importance of transcription factors, which are nothing but important immunological differentiating factors that will lead to the generation of those tumors. We have a whole nomenclature discussion that in 2021 has been favored to have then called as pituitary neuroendocrine tumors rather than pituitary adenomas. In my point of view, this is not as relevant as one can consider. The rationale of this is basically to say that not all pituitary adenomas that we're going to see are going to be just benign and so slow growing, and that's indeed true. There are aggressive invasive pituitary adenomas that require special attention. Once that's said, there is no definition on what is to be considered an invasive pituitary adenoma, and that depends on the basically surgical impressions and assessment. A lot of people consider cavernous sinus invasion as an invasive pituitary adenoma hallmark. I tend to disagree from that, but therefore this just demonstrates how heterogeneous a nomenclature can be. So in terms of different types, as the pituitary is the mother gland of our body, one can have pituitary tumors that will be staining positive for prolactin, growth hormone, ACTH, FSH, LH, or TSH. And therefore, we have the different groups of tumors. So, of course, we got prolactinomas, acromegaly, Cushing's, gonadotroph adenomas, and geotroph adenomas, with the importance to remember that a gonadotroph adenoma subtype is usually silent. So it's not that you're going to have a hypersecretion of a sexual marker, but rather you're going to have a non-functioning pituitary tumor, and they are the most common types of pituitary adenomas on patients older than 50 years old. Here in this figure, you see that the differentiation of the pituitary cells in different lineages happens because of those hormonal transcription factors. And the tip pit gives origin to the corticotroph line, so it's associated with Cushing's, while SF1 and ER alphas are associated with gonadotroph adenomas. And then PIT1 is the lineage associated with somatotroph and lactotroph tumors, therefore acromegaly and prolactinomas, while the geotroph adenomas have the second line with GATA2 receptors. And then there is this group here called no cell adenoma, which is lacks hormonal staining, lacks transcription factor staining, and do have a more aggressive behavior in terms of invasiveness and also recurrence rates. In terms of diagnosis, as we know, like we got a patient with a prolactinoma a pituitary adenoma in our clinic, and if that patient usually comes with either a compressive feature caused by either a visual decline caused by compression of the optic apparatus, or presents with cranial nerve dysfunction as demonstrated by Dr. Shah in a third nerve or a sixth nerve palsy, or even facial numbness or trigeminal pain because of compression of the trigeminal nerve, or that will present with hormonal dysfunction because the pituitary gland can be pushed by the tumor, or if that is a hypersecretion type of pituitary adenoma, namely a geotroph tumor, prolactinoma, acromegaly, or Cushing, you can have hypersecretion syndromes. So in that line, prolactinomas, they will be presented, highlight with, of course, high level prolactin, acromegaly, increased levels of growth hormone, but the most important here now in the new protocol is actually IGF-1 that needs to be elevated. Cushing's disease, it's more heterogeneous in terms of how to evaluate that, but there are three markers that are important: the suppression test with dexamethasone, salivary cortisol at midnight, and 24 hours urinary free cortisol in association with an elevated ACTH. Those are the hallmark features of Cushing's. And TSH adenoma, a combination of increased TSH with increased or normal free T4. So that hormonal profile is always ordered, and you should think about it. You cannot go ahead and do a pituitary surgery without a proper hormonal evaluation. That's key in surgery for pituitary tumors. When we're looking at the MRI, that's the next key point, and the MRI will help you to identify the tumor itself, but also its relationship with the surrounding structures. And in my opinion, the way that I look at the pituitary MRI in a pituitary tumor always includes the size. And in my mind, I already separate between a microadenoma, such as the one that you see here, and a macroadenoma, so the large one that you see here, for example. I look at the relationship of that tumor with the normal pituitary gland, and you see that the gland can be displaced laterally by the tumor or even superiorly or posterior, and that you can evaluate in your MRI scan the presence or not of cavernous sinus invasion. And here the GNOSP classification helps you look at that. The GNOSP classification is good, but it's not perfect. And we know that even when you got a GNOSP 2, for example, sometimes it does invade the cavernous sinus, and sometimes you can get a GNOSP 3A, there is no cavernous sinus invasion. So it's important to keep in mind those different nuances. Optic chiasm compression, yes or no. If the tumor extends into the third ventricle, and the last part, if this tumor is a giant one or invasive one, it has extensions into the cisterns. So all of those points, in my opinion, are important for the evaluation of the tumor that you'll be treating during your surgery. So here you can see that we have this type of tumor. So what is this? This is a small pituitary microadenoma that is not invading the cavernous sinus. This is touching the wall. So this is a NOSP1. The pituitary gland is to the right side as a hyperenhancing tumor. So the adenomas are always hypoenhancing, as you see here. And in this other image here, you have now a macroadenoma, which is extending between the horizontal and the clinoid segment of the carotid. So this is extending into the cavernous sinus. This is a NOSP3A. And you see here the pituitary gland pushed to the right and superiorly. And here, finally, you got one more time a line crossing by this area of the cavernous sinus. Once again, another cavernous sinus invasion. And in this case, the pituitary gland is all the way pushed posteriorly superior into the lateral left side with some compression by the tumor of the optic nerve on the right. So those points are, paramount for a proper radiological evaluation. The other thing that we look at is the cavernous sinus is the most common point, I should say, is the second most common point of extension of those tumors. The primary most common one is actually the suprasellar space contained by the diaphragma, as Dr. Shah mentioned. Most of them are below the diaphragma, but in some instances they can go in between the layers and just extend into the cistern, on the chiasmatic cistern. But the cavernous sinus is key, and here I like to divide the cavernous sinus in two big areas, one in front of the carotid that I call anterior lateral, because it's anterior and lateral to the carotid, and a posterior medial area that is occupying this space posterior and medial to the carotid. We can follow Dr. Fernandez Miranda from Stanford classification, which I find excellent, and subdivides that in four compartments: a superior compartment, a posterior compartment, and an anterior compartment. And he also considers to be a lateral compartment, but that's in reality a virtual space in normal anatomy, but that can be enlarged by a tumor locating just lateral to the horizontal segment of the carotid and in between and medial to the lateral of the cavernous sinus. Visual assessment is key. I do not think that you need like this fancy OCT for all the patients, but I think a visual field exam is quite important for evaluation in the long term. But you should at least have a Snellen test so you can check visual acuity and do a face-to-face visual field test in your clinic before surgery and after surgery as well. In terms of treatment, now that we have talked about how to evaluate those cases, I think we need to, discuss what we are here to discuss, which is surgery. And to remember that surgery is not the only option for pituitary tumors. In fact, it's used in a minority of patients. Most patients with pituitary adenomas have small tumors that can be followed over the years. And unless if that's functioning adenoma, you don't have to do surgery in everything that you see in an MRI. So what are the goals of surgery? Well, maximum safe resection, if possible, to remove completely the tumor, decompression of the optic apparatus so that you can help patients to improve their visual status, preservation of the pituitary function, which can be achieved in most of the cases using using adequate surgical technique, and tissue for diagnosis so that you can understand if that's going to be gonadotroph adenoma or lactotroph adenoma, and define how you're going to follow up those patients. It is important to consider that gross total resection, so complete tumor removal, is associated with higher rates of long-term disease control, and that factors associated with subtotal resection include a previous operation that may lead to higher scarring of the surgical field, cavernous sinus invasion, especially if you are in the beginning of your learning curve, size, so giant tumors or those bigger than 4 centimeters are more challenging, fibrous consistency of the tumor, and surgical experience, surgeon's experience, of course. And that I say here, like, of course, in any surgery, the more experience you have, the better outcome that you're going to have. We do have challenges, and those include the cavernous sinus extension of the dura in the dura wall, including the medial wall of the cavernous sinus, and the reconstruction can be challenging and must be taken into consideration. And it's important to remember that endoscopic endonasal surgery is the best and most important approach for those tumors, but it's not the only approach. And in some cases, those patients can benefit actually from a transcranial approach. For example, patients with a large lateral extension going deep into the sylvian fissure or ambient cistern, and those patients with a large interventricular extension above the foramen Monroe that you may consider not to be amenable to achieve a complete resection through endoscopic perspective. It is very important to remember this aspect here because those tumors with a subtotal resection in a large residual component can have postoperative apoplexy, subarachnoid hemorrhage, interventricular hemorrhage, and poor outcome if not taken care properly. Surgical principles, and of course, anatomy. It's the basis of what we do. It's the first step. If you don't master the anatomy of this region, you basically shouldn't go to the next step, in my point of view. That will lead you to the positioning. You see here, this is from my time in Toronto, actually. You don't need to prep the leg in all cases, in my opinion, but if you get into the habit of doing so, I think you should just go ahead and do it, because if you ever have a vascular injury, you can just quickly open this area, get some muscle from the rectus lateralis, and then use that to repair the vascular injury. But to have elevation of the head with some rotation towards the right side, and you see that I like to operate on the right side of the patient with the assistant also on the right side. So that's the strategy that we usually have. A head elevated to increase venous return, and then also to bring the surgical table all the way down, so your angle of the elbow is actually larger than 120 degrees. That minimizes distress and problems during the surgery. Proper surgical instruments, preservation, identification of the gland, extracapsular dissection as possible, and reconstruction. That in most pituitary tumors can be done either with a free mucosal graft, a dura substitute, or a vascularized nasoseptal flap. So the anatomy, I'm going to quickly just, move on this, but we're going to be working through the sphenoid sinus, and you see here the sphenoid sinus is our main corridor. This is the sala and the pituitary gland here. And what we're going to be focusing on is in the relationship of that region. So this is the first view after completing the nasal stage. We are inside the sphenoid sinus, and here we need to use our 3D X-ray vision. We need to understand all those landmarks before we moving on to the next step. And here you see the sala right in the center of our approach. This is a prominence, and then you're going to have a recess below that, which is called the clival recess. And above the sala, you're going to have this area that we call the tuberculum, but in reality is the prechiasmatic sulcus. And so therefore it's a little bit of a recess. And you see that that's delineated or limited laterally by the optic canal and the clinoid segment of the carotid. And those form therefore the medial optic carotid recess here and the lateral optic carotid recess here. And you're going to see that the roof of the optic canal communicates with the roof of the optic canal with the limbus sphenoidale, which is a dura fold. So you cannot see it there. I just see the projection of it here in the bone. And then everything above the limbus is planus sphenoidale. And then you see all this blue area here, all of this area is the cavernous sinus. We tend to think, or at least I used to think, that the cavernous sinus would just be right here, lateral to the pituitary. It's not the case at all. It actually extends inferior and lateral and goes all the way to the middle fossa floor. And it's limited laterally by V2 in the base of the middle fossa. We open the sala, and that's the first step. And we tend to expose the superior intercavernous sinus, inferior intercavernous sinus, and the medial edge of the cavernous sinus bilaterally. And then if we're exposing, we can expose more laterally for sure when we need to work in the cavernous sinus, or we can expose superiorly if we have a giant pituitary tumor. So different cases will require different techniques. And here we're going to discuss a few of those techniques, starting with a microadenoma and extracapsular dissection, which is my preferred technique for any pituitary tumor, but especially so for functioning pituitary adenomas, especially so if they are microadenomas, and more especially so even if they are Cushing's disease. This first case is a prolactinoma. The second one is a large pituitary tumor with an extracapsular dissection. Then we're going to have a macroadenoma with cisternal extension, and then we're going to have a giant adenoma as well. So first case is a 32-year-old woman with 2 years history of irregular menstrual cycles, compatible with a prolactinoma. She did attempt medical therapy with dopamine agonists, but did not tolerate the medication. She had side effects, including mood disorders and nausea. So her prolactin was 150, and this was her MRI. And then you see here the tumor on the right side of the cella with no invasion of the cavernous sinus, and the pituitary gland is on the left side. So this is the surgery. You see here, the sphenoid sinus is open. This is the cella. And then here using a diamond burr. So the surgery to me, it's like following a cook recipe. It's in a way always the same steps. So this is drilling the bone. I always use the same drill, working around the bone of the cella and then mobilizing that cella floor. That then allows us to remove the bone a little bit more lateral because, as I said, we'd like to get that edge. So you see here the edge on the cavernous sinus on the right and on the left side as well. Once that's done, we're going to be open the dura, and then the dura is open. After the dura is open, we basically have to separate the dura from the pituitary capsule, so preserving the planes. And then you're going to see that you see the normal pituitary gland, and on the right side here, we have the pituitary microadenoma itself. And then what we would do, like you can basically retract that gland gently and be very, very gentle with the maneuvers around the capsule of the adenoma or the pseudocapsule of the adenoma. And so you have to mobilize from the lateral aspect, from the medial aspect. You see here the separation with the gland has been already created. This is a 5 millimeter malleable suction, and this is a Castel Nuovo dissector separating the tumor from the floor in the dura, and then just going all the way to the back. And then as that's done, this tumor is already, you see here, it's already herniating, so it's almost completely out. Now it's completely out, and then you can basically send that to pathology. That is the tumor completely removed, and then we're just gonna irrigate and I'm gonna coagulate some of that pituitary gland on this side just to make sure that there are no cells left. That shouldn't be the case, but still, I'd rather be safe than sorry. You see here coagulating that wall. No CSF leak, no pituitary injury, no vascular injury, just a little bit of gel foam in that area, and then we're going to place a dura substitute, which for us here can be done. It's cheap here. I know that's not the case everywhere. I'm from Brazil once again, and if anything, you could just place like some Surgicel there, and that should be enough. So this is the post-op scan. The most important aspect is the prolactin level went all the way down to 18. Case number 2, a 53-year-old woman with some memory changes, increasing in weight, weight loss, and some, bruising. The MRI demonstrated this mass that you're going to see here, a large heterogeneous mass extending to the suprasellar space, pushing the optic chiasm, and originating from the cella. And you see here that this has a complex shape, a mix of solid and cystic components. We went ahead to do surgery to decompress the optic apparatus, and following the same principles. So I drilled always in that way. I tend to drill in an anti-clockwise fashion, but there is no specific, direction. You can drill clockwise, anti-clockwise, but often I like to remove this in block here. That is leading then to fully exposure of the dura. And then you see that I'm here limited by the carotid. I don't need to expose the carotid in this case. Opening the dura, finding the anterior surface of the tumor. And then we can once again dissect the plane, separating the tumor from the dura mater. And that then will lead us to get the tumor fully exposed. You see here that everything that I see in front of me, it's actually gland. The gland is in front of us. So that's the orange aspect of the gland. And then here in this case, I'm cutting the inferior quadrant of the gland to get access to the tumor. And the tumor has this, liquidy kind of aspect that is compatible of a complex Rathke's cleft cyst, as some of them can differentiate over the years to adenomatous craniopharyngioma in the spectrum of differentiation. Anyhow, we're here inside this tumor now, just debulking a bit and trying to find the walls of this tumor. And as that's done, you can see that I finally found the wall. This is the gland, and here's the wall. So I try to do that to mobilize the tumor with no problem, using now a 3 millimeter 45-degree curette by Capabianca curette. We can mobilize that, and with some microdissection, I can transect some more of that tumor inside. mobilizing the tumor from the bottom part of the cella floor all the way to the dorsal cella, allows us to lift up that tumor. And then I'm gonna go and mobilize that laterally. You see that the tumor now on the right side has been dissected away from the gland and from the medial wall of the cavernous sinus. And then finally gonna repeat that same movement with the left side until we get all the way up. And you see here, I'm protecting the gland, but bringing that tumor, rolling that tumor down. It is an infradiaphragmatic tumor, so I can do this confidently and with no concerns. I'm not going to be pulling a vessel because there are no vessels or big vessels below the diaphragm. So I'm safe with this maneuver. And then as this tumor is, progressively rolled, you're going to see that going to be gentle with that part on the top between the terminal and the pituitary gland. And then finally, in an extracapsular fashion, going to be able to rotate that tumor and then get a complete removal. And there you go. So the tumor comes out. The most difficult part was to get this thing out of the nose. And then we're going to be looking at the end of the surgery, the pituitary gland in the front. You're going to see the diaphragm that descended. This is the aperture of the diaphragm here, and you can see the pituitary stalk all the way in the top part and the aperture as we were discussing. So here, just very low flow, low pressure CSF leak and reconstruction with a dural substitute was enough. So this is the post-op scan. And you can see here the extent of resection that was achieved with the pituitary gland and stalk preserved. Case number 3, this is a 77-year-old man, had a previous subtotal resection 10 years ago, had a previous intervention, had serial MRIs that demonstrated increasing size, had worsening balance, gait problems, but no visual changes. And then comes to us with this MRI here. And then you're going to see that now it's a completely different game. So now this is a tumor that we will extend to the cisterns. It has 2 components. One that is the new component growing. This is the old component extending, towards the roof of the cavernous sinus on the right side. And then here you're going to see that again on a sagittal view. That will be extending all the way up with 2 basically components, one on the left and one on the right side. So once again, visual changes and cognitive changes, surgery is recommended. I'm going to skip the nasal stage of the operation. This is what we got here at the sphenoid sinus. So opening up the tumor, the dura of the tumor, and then debulking that mass using a combination of bisuction technique, where I retract with one suction and suck with the other one, and then also microsurgical dissection with micro scissors and micro dissectors. The tumor is progressively debulked, and then you see that I then continue cutting that capsule of the tumor so that we can mobilize that progressively. And then as I find the edges of the tumor on this left side, I can mobilize that in an extracapsular fashion. Once again, I roll that tumor from extracapsular from superior to inferior, keeping that suction on top so that you can hold the diaphragm there. And then here, I just go dissecting that plane and separating that tumor from the diaphragm and from the pituitary gland, which is on the top here. So as that is done progressively and gently, this tumor is being mobilized, and then you can finally get that as a in-block extracapsular resection of this large pituitary tumor. You're going to see that this component was removed, and that looks very good. But then here, I had to chase a residual component because I knew, based on the MRI, that there was some component extending into the cisterns on the right side, which was a problem. So here go with angle. This is a 30-degree endoscope, looking all the way up and trying to find a way to get that tumor out. But it's a challenging one as it goes into the cisterns. So I go and I do a lot of work in that area. This is all the diaphragm descending here. Basically at that time, I decide, okay, this is what I'm going to get, some multilayer reconstruction. And then you're going to see that in this case, I can see a very nice decompression, but I can see a small amount of tumor here on this right upper corner. And that's a combination of a fibrous consistency of that tumor and that extension in the cistern. So you see that despite a quite good looking resection, there is some tumor left in that area. Thankfully, this was a gonadotroph adenoma that descended over time, and it's currently being followed with no signs of further progression. But I know that it can grow over the years, so we need to be prepared to take action as needed. Case number 4, this is a 72-year-old woman with vision decline in the last 6 months. And then take a look at this. This is a very, very different type of tumor compared to the first ones we showed. So this one has a suprasellar extension and extends into the ventricular system on both sides. Here it goes on top of the plano. This is a sagittal view and extending, pushing the base of the frontal lobe and with close relationship with the anterior cerebral arteries. So this is the type of case that you need to have a very good experience with endoscopic endonasal approaches and a good years doing this to try to attempt this only with an endoscopic endonasal approach. If you yet do not have that, you should consider this for a combined open, like a Teriono and endoscopic endonasal approach, because if this component up here is left, so this is a residual, if this is a residual after surgery, that can bleed, and your patient can have, poor outcomes because of that bleeding. So the surgery here, now you're going to see that's not anymore sellar surgery. Now we're going to expose, you see the optic canals, you see the sella, the clinoid segment of the ICA. I'm going to expose the sella here, but I also going to go and I'm going to drill all this bone in the planum and the tuberculum. So that's what is being done there. And then you see tuberculum is exposed, planum is exposed. I'm going to open the dura and the sella. And then I see here some tumors, some normal pituitary gland. I'm going to open the dura in the suprasellar space. So this is CSF coming from the chiasmatic cistern. And then this is the tumor that you observe right here, okay? So we start with the debulking, and then after that, what we're gonna see is we're gonna observe that as I debulk all the way in the back, I need to identify the vascular anatomy. And here I see the anterior cerebral artery A1 segment on the right. I saw A1 on the left. So we got A1 on the right, A1 on the left, optic nerve on the bottom part. And then I go from front to back. And I need to remember vascular anatomy. So I need to remember that the lenticular striate branches, they will be coming from the posterior superior aspect of those vessels rather than from the front. So if I stay in the front wall of those vessels, I'll be generally safe. The bulking continues. You see here the left optic nerve. I can continue to mobilize all that area, cleaning up around the optic nerve on the right side. And then I'm just trying to separate the optic nerve from the residual stalk and pituitary gland. Here, I'm mobilizing some of the tumor, and this is actually pituitary gland all the way in the back part. So this is the arachnoid with superior hypophyseal branches and the stalk. And then I can go separating all of the tumor from that area. As that's completed, I'm going all the way towards the anterior cerebral artery, anterior communicating artery complex, and then further debulking, going all the way up. I need to see the A2s, and I start to see here the A2 in the middle. This is a frontal basal artery, and this is the cyst that will take me then to the anterior horn of the lateral ventricle on the right side. So the horn is right here, the frontal horn, and this is a very unique view that you can get to see, in this case, seeing the frontal horn of the lateral ventricle from below, which is something that we don't usually see. So this is the most frontal part. I didn't open that to avoid a high flow CSF leak. Some brain mobilization here around the ACON component. And here you see just cleaning up that top of the tumor, leading up to this, very nice resection. This is a high flow CSF leak. So this is a multi-layer reconstruction. And here we're going to use some gel foam. We're going to use some dura substitute, some fascia lata, and a vascularized nasoseptal flap. This is the post-op result, and you see here the flap that is enhancing a complete resection of this mass. This patient did well. Well, then this is all in the so-called sagittal plane. And here to finalize, so I don't extend too much, I want to basically demonstrate to you the cavernous sinus extension. So here, we looked at this sphenoid, the sella, the suprasellar extensions, and now we're looking towards the cavernous sinus on the right side, and we got the transpterygoid extensions that oftentimes we don't need to do. The only thing that I want you to know is that each part of the cavernous sinus has an important relationship. The superior compartment is located on top of the horizontal segment of the carotid and will be related with the posterior clinoid process, with the interclinoidal ligament and the third nerve. And the posterior compartment has no relationship with the third nerve, but it's actually related with this piece of bone here that we call the petrous process of the sphenoid bone, and with this sixth nerve as it crosses from the prepontine cistern in inferior to superior and medial to lateral direction, running towards the Raylos canal and then running lateral to the vertical segment of the carotid and the cavernous sinus, and finally in the cavernous sinus itself all the way to the superior orbital fissure. The anterior inferior space, located anterior and inferior to the carotid. The most important structure here is actually the sixth nerve as it crosses just inferior and lateral to the horizontal segment of the carotid in the cavernous sinus as it runs towards the superior orbital fissure. Once again, different techniques, different cases. I'm not going to go into every and each one of them, but I'm going to highlight a couple of them. This is a case that I often show to demonstrate the importance of the anatomy of the carotid and the cavernous sinus. We have this giant adenoma, and I'm going to get a prolactinoma of invasion of the cavernous sinus, and then this Cushing's case. So let me select a couple. I'm going to select this one. So this is a case that he is 52 years old with a gonadotroph adenoma, had 2 surgeries in the past, but there was always residual that was left too close to the carotid. Correctly so, the surgeons that did the case maybe felt that they didn't feel safe to remove it, but that is okay. But during follow-up, you see that this tumor had continued to grow, and here in 2022 was once again causing compression of the optic nerves and visual decline. It was also invading the left cavernous sinus, pushing the pituitary gland superior into the right, and leading to all this recurrence pattern in this case. So what do we have to do here? Surgery, and that's a very complex operation because this patient had 2 surgeries before, no vascularized flap option, but we got to do what we got to do. So this patient, we needed to extend the bone opening, and then we needed to identify the carotid and clinoid segment. But to have proximal control, I needed a carotid in the cavernous sinus in the vertical segment. So I started debulking this tumor and sending some tissue to pathology and trying to get that vertical segment, which I know is going to be here, but I can't see it yet. So I have to use a Doppler and debulk the tumor, further debulk the tumor until the point that after debulking a lot of that, I can get to this area that you're going to see right here. And that white shiny structure that you see right there, this is going to be the vertical ICA going up. Once you get the vertical ICA, we're safe because we are aware of the vascular anatomy. I know that the only thing that can bleed is going to be right here. That's the meningohypophyseal trunk. So we can separate that and get this very nice view of the carotid. So vertical segment, I'm going to show you in the end. Then after that, I could get the tumor, being careful to preserve the planes to avoid a leak. But after that resection, you basically can see the vertical segment of the carotid, posterior genu, horizontal segment, anterior genu, and the clinoid ICA here. So you can see the entire carotid in this case. As we were careful, you see the diaphragm is pulsating, no CSF leak. The gland was here to the right, and that was a very successful operation with improvement of the visual status of this patient and a gross total resection of this tumor. This is the gland here on the top side. This patient did have a partial third nerve palsy, some ptosis that improved in 2 weeks. He did not need any additional hormonal replacement. He did not have diabetes insipidus, and he did not have a CSF leak. I'm going to skip this case for the sake of it. I'm going to use an example of medial wall resection, and this is a very nice example here. This is a 67-year-old patient with prolactinoma that was found to have this tumor that actually was a pretty midline tumor according to this image. This is blood in the sella. We followed for 6 months. I was expecting this to actually decrease and to have a full resolution because of the apoplexy, but that did not happen. So we ended up going to surgery, and then you're going to see here in this case that this is the approach. So classic approach, nothing too different. Opening the sella, we can see some old blood in there. and then that tumor is being mobilized and resected. And then we can see here the wall of the cavernous sinus is infiltrated. So basically, to remove that, I need to open the wall. Then I'm gonna drill the anterior face of the sella, inferior laterally here, I'm sorry. And then after that, I can use a Doppler to map this area. This was negative. So here I'm opening the anterior wall of the cavernous sinus. Then I'm gonna basically stop the venous using with hemostatic pounders, surge flow, flow seal. I can open this anterior wall with a feather blade, and then we're gonna be separating this medial wall here, which is already identified, and removing all of this synergy pathology, so we can get a a maximum resection of this area. So as this is removed here, you can see the carotid is just here, just lateral to my Caesar, and then I can get that tumor, that tissue completely out with tumor. This is the posterior clinoid being exposed here, and the carotid is right here. So this is a complete resection. This patient achieved a complete removal and improvement of prolactin levels, went all the way down to 4, and is in disease remission now. I'm going to skip this case for the sake of time. I know it's getting pretty late in there, and also this case. But in terms of results, this is an old slide. I thought I had updated this one here. Actually, I have 28 cases now of medial wall resection. This is the slide here. And we got 92.3% of disease control, no injuries of the carotid, no CSF leaks, and you see an excellent disease control rate. That is in line with previous results that we collected from the literature, which has been published demonstrating a control rate of about 90 to 94%. And we have been successful in doing this and applying this post-op day 1 discharge protocol that is only really impacted when we got lumbar drains in place or a diabetes insipidus. Well, in conclusion, modern endoscopic skull-based surgery has improved results of pituitary adenoma resection, and to achieve that, we require anatomical knowledge and understanding of cavernous sinus and medial wall resection. Skull-based microsurgical training remains key for development of new techniques and improvement of the learning curve, following the principles of our masters, such as Evandro and Roten, of gentle, accurate, and safe surgery, and always seeing surgery as an art. I like to thank the team that I work with here at the Mayo Clinic in Florida. I'd like to invite you all to be joining us in our skull-based lab. And I'd like to thank all the trainees and fellows and visiting people team that have joined us over the last 1 year here. And I'd like to invite you all to the course that we have here in May at Mayo in Florida from May 20 to May 24th. This is a QR code that you can point to and get information to the course. And finally, this is my email, and I'm more than pleased to answer any questions now or later on via email. Feel free to be in connection. So thank you very much. It's a pleasure to be here with you guys.
Thank you, Idris, Professor. It was a great presentation. I am so grateful for being with us, and I wish we can have another meetings and lectures later. And personally, I hope to meet you soon, face to face in the soon future, sir.
My pleasure. My pleasure.
And Dr. Almeida, we're trying to get some Japanese people to network. We're doing our best, and we'll keep in touch.
No, absolutely. I see there is a hand that is raised, Jean-Pierre Kalala. I don't know if that's a question that Jean-Pierre has.
I wrote the question.
Oh, my bad.
Hello,
I mean,
do you hear me?
yes, I
hear
do,
me?
sir. I do.
Yes.
Yes.
It was really a nice presentation, very interesting. My question, you didn't say anything about navigation. Don't you use it?
I do.
Neuronavigation.
That's an excellent question. So we do have navigation for every single one of the cases, but I have to be fully honest and transparent that I have it in the room, I have it available. I really rely on the surgical anatomy in absolutely 98% of the cases. The one thing that helps me a lot during surgery, and if I were forced to have to choose between a neuronavigation and a microdoppler, I would choose a microdoppler, because oftentimes the limiting factor for the resection is actually the carotid rather than any other structure. And to me, that identification of the carotid is key, and I find it way more useful to rely on the Doppler to have that identification rather than the neuronavigation. So my ENT colleagues, they use the Doppler, I mean the navigation routinely. I do have that if I need to, but as I said, I think in the last 2 years, I think in a couple of cases I relied on it. There is nothing wrong about using the navigation, absolutely nothing wrong. But to me, what I really rely on is the anatomy of those prominences in the Doppler.
Okay, thank you very much.
My pleasure.
Tariki asked for the link to the Mayo course. Did you put that up, the link to the
I'm gonna
Mayo?
put my email here,
Okay,
and I'm gonna see
yeah, the link to the
if I
conference.
can get the link here right now. Maybe we can go to other questions while I find this link as well.
Okay,
Hi, John.
go ahead.
Hello.
Hi, JP. Thank you for the
Hi,
wonderful.
hi. How are you?
I'm fine. Thank you for the wonderful lecture that you've gone through. I had three questions I wanted to
Of
ask.
course.
So the first question was the role of medical therapy, especially in patients with the hormonal active tumors like prolactinomas.
Mm-hmm.
In your experience, do you usually put them through hormonal therapy first before you go for surgery, or are those patients who you go through for surgery as a first indication? So that was the first question. The second question, sometimes you get patients who have relatively low hormones, especially cortisol and thyroid function tests. So in my center, where we have so many patients who sometimes we don't get the opportunity to operate on them at first. Sometimes we put them through medical therapy just to put their hormones in a normal level. I don't know in your experience, do you, especially in such patients, do you put them through hormonal therapy, or sometimes you go through surgery the first time you meet them? Then the third question was about pituitary apoplexy. I saw in one of your cases, you operated on the patient after some time. In some studies, they say that you can actually operate in the first week after you've put them through a dose of cortisol. I don't know in experience, do you usually treat them with the hormonal therapy, maybe hydrocortisone, and then you go for surgery? Or there are patients who usually operate on them the first time? Thank you, JP.
Hi, Jeremy. Well, excellent questions. So let me start with the first one then. So for especially for prolactinomas to start with, in the absolute majority of prolactinomas, medical therapy comes first. And I think that's very important to be understood. That's key, right? Because we know that especially in men, prolactinomas tend to present themselves as a very aggressive, invasive tumors, going to all different crazy places, and would be extremely challenging tumors to undergo surgery. So thanks God we have the medical therapy available. That's namely bromocriptine or cabergoline. The big challenge is that not all patients respond that well for those, to those medications. So, in fact, there are two challenges: the population that do not fully respond to those medications and may require progressively increasing doses of those dopamine agonists, which oftentimes in the long run can cause valvulopathy, so cardiopathies because of that. And of course, we want to avoid that problem. In the second population, which is the one that presents with side effects to dopamine agonists. In that sense, those are the two most common indications for surgery in prolactinomas. So long story short, medical therapy remains as primary treatment recommendation for prolactinomas. Once that's said, nowadays more and more people, including myself and Susan Sampson, the team that we work here at Mayo, Florida, we tend to look at very selected microprolactinomas that we believe that we can achieve disease control with surgery as potential targets for surgery as a first line of therapy. Of course, that requires a lot of confidence in our surgical results. I wouldn't offer surgery for someone that I think I wouldn't, really get at all. So I need to be very, very confident on our ability to achieve disease control. But it's definitely as an option, not as a primary line of therapy. For the second question, well, and I mean, if we are to discuss about Cushing's disease or acromegaly, so Cushing's is a surgical disease. I don't think there is any medication that really plays a role as primary therapy. In acromegaly, then that's really there are some medications that can play a role for intrinsically only cellular tumors, but those oftentimes are very expensive, require long-term therapy, have disease control rates that are inferior to surgery, and therefore I don't see them as primary therapy for patients. Actually, it's much better and cheaper to try surgery first for any population, in my opinion, in any place on earth. And then gonadotrophic adenomas, that goes into the second question that you brought up. So for patients that come to clinic, and if you have a clinic that is busy and there is a waiting line, I think that is an option to consider medical therapy starting with. So let's say that you have acromegaly, or you have a Cushing's patient or a prolactinoma patient that for any reason you need to operate, but you cannot operate right away. I think that's a good justification to start with medical therapy. And I think that of all the populations that we discuss, I think that Cushing's is the one that benefits the most. So if you're able to bring down some of that hypercortisolemia before surgery, that can be beneficial to that patient, if that patient will need to be waiting in line for a while. So I think that that's something that you can play around and I had experience in Canada and Brazil, and now I'm here. Here things move a little bit faster, but in those other countries, I think that's a technique that works well, and it's needed in good parts of the planet. And then the last question in terms of pituitary apoplexy, in my point of view, for small tumors that are not causing visual decline, namely visual acuity deficiency or deficits, or visual field deficits, therefore, even if the patient has some third nerve or sixth nerve, conservative management is still an option. And that's why, and then we have results that we published ourselves, results that have been validated further by a paper that we were part of it now, called the PASTOR study, that came out in the endocrinology journal this last year of 2023. We have evidence that conservative therapy can be used in those cases, and had to be equally effective, actually, than surgical therapy. So in my opinion, surgical therapy becomes well indicated if you have a tumor that is large in size and is causing visual field and/or visual acuity deficits, especially if at least a hemianopsia. Otherwise, conservative therapy can be attempted. That varies from place to place. That's something that I get into controversies here from time to time. So I don't think it's a unique answer. One can say that if you don't have visual decline, but you have a third nerve palsy because of that yes, that patient can improve over time. But if you do surgery, you can have a faster recovery of that third nerve palsy. And I think that may be true. But long story short, to answer that question, we will need a trial, and I don't see a trial coming up anytime soon for that. But those are, overall the way, that I see this. And just in line of the hormonal point that you brought up, I think it's very important to remember that for the patients that present with hypopituitarism because of the tumor, like big tumors that compress the gland, they will need, of course, endocrinological follow-up and medical therapy. So thyroid replacement, cortical replacement, and testosterone replacement, and sometimes even GDAVP or desmopressin. And even in the best hands, with the best surgery, the rates of recovery of any of those axes is of only about 10%. So those patients oftentimes will continue to need medical therapy despite amazing surgery. So endocrinology will forever play a major role in the management of those patients.
Very good, Ahmed. Ahmed?
Yeah, sir.
Yeah, go ahead, Ahmed. I think we got to close.
Mhm. Well, I would like just to thank Professor Go for being with us, and again, I'm so appreciated for having this opportunity with Your Excellency. So thank you for Your Excellency, and thank you for the attendees, and also I'm so appreciated for Dr. John Bennett for supporting us and giving us the opportunity to have this scientific events on Neurosurgical TV. So thank you for being with us, Professor, and thank you, John, for your support.
Okay, great. Thank you, Ahmed, for your support, and Zhao, thank you for your valuable time.
Thank you. Always a pleasure.
Okay, good
Bye-bye,
night,
everyone.
everyone. Good night.